Good afternoon to our viewers. We take the opportunity to welcome you to another edition of Let's Talk. We are delighted to come your way this afternoon. We have been for the last few weeks discussing the subject of cancer and the Christian. It has been truly an amazing journey. We have learned so much. So much has been revealed. This afternoon, our special guest, Dr. Natalie Greaves, is back with us, and she is going to be guiding us in sharing, explaining, responding to questions. But before we go into the broadcast for today, we would like to invite you to bow for a word of prayer. Almighty Father and our God, we thank you for the opportunity and privilege to be able to come via social media one more time, and also via Second Advent Radio. We pray that you will be with all of those who are listening. Some are moving about in their vehicles, others are maybe around the dinner table, some, oh God, on their phones. Wherever people are, we pray that you will give them understanding. Be with our guest, Dr. Graves, as she shares with us today. And may the information prove meaningful in Jesus' name. Amen. My friends, as indicated, last week we were discussing, for the last 2 weeks, we have been discussing cancer. Last week, we looked specifically at colorectal cancer. And, Dr. Graves has been with us, facilitating this discussion. Dr. Graves, just in case you're joining us for the first time, she is a cancer researcher. She's a lecturer at the MPhil campus of the University of the West Indies. She coordinates the program in public health, and she also manages cancer research for the government of Barbados. She is into palliative care, and hopefully, I'm saying this with a degree of caution, hopefully next week we will have her when we can discuss some issues relating to treatment and palliative care and how we handle people in their dying moments, those who cannot recover. But for now, I want to begin, Dr. Graves, by asking you, last week I was just amazed at your explanation of colorectal cancer. Unfortunately, we ran out of time before we were able to address some of the concerns and questions that were raised. So let's begin with looking at some of the questions that came out of last week's discussion. First, you mentioned that one may see blood in the stool or on the toilet paper that they used to wipe, and these may be symptoms that something is wrong. What other symptoms may there be to suggest that one may have colorectal cancer?
Okay, so firstly, thanks, Dr. Greene, for having me. There's just two little things in my bio that I just want to correct because they sound very grand in terms of because I know some persons would have missed the first bio. So
Okay.
the role that I have with the government of Barbados, my substantive is with the University of the West Indies. I'm an honorary medical officer of health, and my responsibility is for writing cancer guidelines. So I'm not in charge of cancer, all of the research on cancer for Barbados. But that is an idea, thanks to that. But it's really about the guidelines, particularly for breast, prostate, colorectal cancer, because those are the big three. So happy to talk some more on colorectal cancer. For those of you who missed last week, we would have covered lots of definitions about what cancer is, what a benign tumor is, what a metastatic tumor is, etc. And we focus down at the very end about colorectal cancer. We're talking about cancer that involves the colon, which is the last part of the large intestines, really the last part of the digestive system, and the very end, the rectal anus region. And what we were speaking about, specific to your question, is the fact that sometimes when there is a growth and that growth is cancerous, we didn't say that all blood in the stool equals cancer, but sometimes that is one of the manifestations that you can see depending on the area of the colon that is involved, especially if it's the lower left side, very low. The blood will actually be like a bright red blood, like a fresh blood. and you can see that when you wipe, etc. If the blood is coming from the right side of the colon, the stool has more time to mix in with that blood. That blood has more opportunity to get altered, etc. And you might not see it, right? You might not see it at all. And that is the significance of picking up, doing those tests, those screening tests that can pick up when blood is in the stool when it ought not to be. And particularly for those right-sided tumors. So last week I mentioned also about men and men with iron deficiency anemia. And this is connected to that point, in that if you are losing blood or blood is leaking out into the stool, you will pick up a change. There will be a change in your iron levels. And especially in men, if you are picking up that a man's iron count is low, it would usually suggest that something is going on with the body. It could be the way how the cells are being produced, but it also could very well mean that there is a place, especially in the gastrointestinal system, where blood is leaking. So that's the significance for men in particular. But even in women, especially postmenopausal women, where we're not having a menstrual cycle every month, etc., and you're not expected to have some form of blood loss, etc., if you have an iron deficiency anemia, us as doctors, how we are trained, we're always made to take a gastrointestinal history just to make sure that someone is not having a challenge there. So I'm hopeful that I answered that question. Yeah. But you asked me what are the signs and symptoms, yes?
Yes, yes,
Right,
that's right.
okay, good. Right. So other signs and symptoms relate to the side of the colon or the part of the colon that is involved. So we talked about the right side. So the right side of the colon, on the right side of the body, it tends to be the lumen, the space in the middle tends to be wider. And because it tends to be wider, you might not get a problem, and the stool is not fully firm there on the right side. It's kind of mushy. So you might not get changes in bowel habits if the tumor is on the right side, but you might get right-sided pain. So on the right side of your tummy, you might feel a pain, and also some people might get a sensation of bloating, etc. As the stool moves naturally through the colon up the right side and across the middle part and then down the left, more and more water is sucked out of it, and therefore it gets firmer and firmer. And if you are having a challenge in the middle part, what we call the transverse part, or the left side, especially where the stool is very firm, you might actually get a very strong colicky pain, like what we will call like a cramping, like a gripe, and that can tell you that something is going on. Worst case scenario, some persons actually get a mix of constipation with diarrhea. So we call it altered bowel habits, where sometimes because of the narrowing that is occurring, the stool is not getting through as it should, and you get constipation. But then you may get some liquid stool flowing over that, and you may get a constipation mixed with diarrhea. The other thing that can happen is some people can get bloating, and worst case scenario, you can get an obstruction, meaning that no stool is passing. You feel very, very uncomfortable, and then some people may have vomiting, etc. So that's one of the things that can happen. So the symptoms really match to which part of the colon is affected. If you have a very low lying tumor on the left side down into the rectum, you can get pain. It's kind of like a burning pain in that muscle sometimes, and you can get a sensation of a heaviness when you sit down. And then also, if the tumor is impacting the glands that God has made just at the exit point of the anus, some people can get a lot of mucus being produced as well. Now, separate and apart from what's happening with the stool and the mucus and the cramping that you may get and the bloating, in the Caribbean and many other countries, if persons are missing the signs, the early signs, and they are also not having screening done, because they really want to push today the screening message, like get checked, don't wait for symptoms to happen, because sometimes when you pick up on a symptom and you actually move, things might have progressed more than you have wanted them to. So worst case scenario, some people may start to go to the doctor when they realize that they're losing weight, and they're losing weight when they did not plan to. So you haven't changed your diet, you have not, you're not exercising more, but you're still losing weight. Or if you find that you're tired, so you've gone to sleep, you rested the 8 hours or whatever is your norm, but when you're waking up, you're still feeling tired, that's something. And then also, if you're losing that blood, especially You can get signs of what we'll call the iron deficiency anemia. So that would be tiredness again, but it could be also shortness of breath, dizziness or lightheadedness, feelings of palpitations, and those kind of things. But I think the message that when we started 2 weeks ago, what we were saying is sometimes when people hear cancer, they can be fearful, even as Christians or non-Christians, matters not. Persons, the human response sometimes is one of fear. So sometimes when you're picking up signs and symptoms in your body, there may be a delay in seeking care because you're kind of concerned about what might this turn out to be. But we're saying in the case of colorectal cancer, there are screening tools that are affordable that people can avail themselves to way early. Get yourself checked. If something is happening, help to get it resolved, because current estimates suggest that when colorectal cancer is picked up early, very early, it's a cancer that can be cured. Does that help now, Doc? For some reason,
I
Dr.
think I was muted there.
Yeah,
I
yeah.
was saying definitely that did help.
Okay.
Very significant. Again, a lot of information, but I'm glad you are. In fact, my next question was going to be, what happens if people do not screen and they wait until too late to
Yeah.
respond? I suppose that could be pretty dangerous.
Yeah. Yes. Yes. So I think one of the key messages that we're saying here, that the evidence is growing sufficiently to say that a lot of cancers can be prevented. And where cancers cannot be prevented or have not been prevented, if they are picked up early, you can change the course of the outcome. Yeah, we talked last week about prognosis. We can change the prognosis. We can alter the prognosis by seeking medical attention and seeking that medical attention in a timely manner. So the earlier, technically, is the mantra is the earlier the level of detection in terms of the stage, and I know this is something that you're interested in, and I will explain it, the better the outcome. So when we talk about cancers, we have all of these nice categories and ways of thinking about things. And one of the words that you will hear bandied about is the stage. And when we speak about stage, we're talking about the extent or the degree of spread of the cancer in the body. Okay, so the extent meaning the size and what it involves, and also the degree of spread. Because as we said before, cancer cells, they have the ability to move from where they were originally supposed to be. They can move to someplace else. So usually the stages, there are these nice fancy ways of like fitting different kinds of characteristics to come up with a particular answer. But the main stages, regardless of cancer, this cancer type tend to go from 1 to 4. Okay, so the tinier the cancer is, and the more it's not affecting anything around it, and better yet, if it's not spread to anything at all, that is the best. So you want to pick up any kind of cancer when it's very, very tiny in terms of the size, when it's not involving the things that are right next to it, which is local extent. It's not involving any of the lymph vessels or any of those channels that God has designed, and it's also not spread to other parts. So if you wait too long for colorectal cancer, it might have spread through the different layers of the colon. So the colon has different layers from the inside out. It might have spread to the channels, the lymphatic channels in the tummy. It might have spread, colorectal cancer likes to spread to the liver. It might have spread all the way from the colon up to the liver. So what we're saying today is it's an easier thing to adjust your lifestyle to prevent, to tap into screening as early as possible. If there's something happening, deal with it, as opposed to watching and waiting. Yeah.
Not, there are two things I want to just follow up on there.
Sure.
I was going to say you seem to be anticipating my questions because
Oh no.
I was planning to ask you about the stages, but since you mentioned it, let me go ahead,
Sure.
because you started saying, if the cancer is not malignant, if it has not metastatized, I want to make sure I'm using the correct words,
Yeah.
So, and then you said, but you didn't kind of complete that thought. So
Okay.
can you mentioned 4 stages. So before we come back to my next question, which is going to be about, the whole concept of lifestyle change, um, can you just go over for us the stages? You mentioned 4 stages. What are the characteristics of these stages? If that is you're able to explain that.
Sure.
We can get a sense when I hear a person has stage 2 cancer or stage 4
Right.
cancer, what does it mean?
Okay, so I'm always looking I was looking for things to help me to explain. And I think I have some stuff here on my desk that could help me to explain. So the staging system, I'll go over again. The staging system is the a way of categorizing how cancers are behaving in terms of where they are located. So their size and their proximity to others. So the thing about it is, if I have a cancer in my breast, the staging there might still be 1, 2, 3, 4. The staging for my colon might still be 1, 2, 3, 4. Any other part of my body might still be 1, 2, 3, 4. But in that particular category 1, the description might be slightly different for the breast and slightly different for the colon. So what
Okay.
I'm going to do, I'm going to give you the general rule. Okay?
Yes.
The general rule. So the general rule, we talk about T, an N, and an M. Now this is a full-on, I'm going to make it really, really simple, but this is exactly what we teach the medical students. The T is the characteristics of the tumor. Yes? So
Mhm.
this is big, but I don't mean it to be so big. So the T is the tumor. So suppose this is the cancer cells. Yes?
Yeah.
Then the N is the nodes. Okay? So how we are made that we have these channels that flow through our bodies that kind of help our immune system, and they carry some important elements, and they drain things. So suppose this is the tumor. Close by the tumor, there's going to be a drainage system. Yeah? So I have my tumor, which is my T. I have my N, which is a characteristic of my drainage system. And then I have, now don't ask me why I have this on my desk, but I do. I have a Santa Claus hat. I have a 3-year-old, and she's been playing with this. And the M is the metastases. So it's far away from technically where the tumor is. So if you have a tiny, 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 tiny tumor that has not usually involved the nodes, and it has not spread anywhere, that's usually a really good thing. And that's like a stage 1. Yeah? So you
Yeah.
want things, I'm going to crush my box. You want to find things when they're really, really tiny. Now, if you have a tumor that is bigger, yeah, and is usually starting to involve some of the nodes, this is the general, but remember the specifics may be different, and it's
Yes.
starting to involve the nodes, that is going to be like a 2. Yeah? Now,
Mhm.
usually a 3 can be any combination of a couple things, but usually the tumor is probably pretty big, or it's getting larger than you would want. It's involving a node, and it's probably hitting up against a structure that is very, very nearby, but it's not metastasized. Okay? Now, the funny thing is, it doesn't matter what's happening with the size of your tumor. It does not matter what's happening with your node. As long as the tumor has spread from wherever it was originally at and it's gone to some place further away, it's automatically a 4.
Okay.
Yeah. So I think that's why, at least in Barbados and people that I've interacted with, people kind of panic when they hear 4, because they may not understand, but 4 does not equal death. Okay? Because people say, oh, it's stage 4, and that means I am going to, you know, it's really, really, it is, it's not the final stage in that death is imminent, like around the corner, but it might be the final stage in terms of our categorization. Does that help?
So yes, definitely. So stage 4 is when the cancer has metastatized. it has spread to some other organ or place in the body
Distant from where it
from where it
started.
was. Yeah,
Yeah.
but even at stage 4, it can still be treated, can still be,
Yeah.
there's still hope.
Yes, there's still hope. Now, what we might caution against is that you might not be able to cure, but you may have a good survivorship. Okay, because usually it might be more complicated to achieve cure. But if it is just stage 1, you can imagine if it's really tiny, you can just, if it's something that can be removed by a surgery, you can just take that out. If it's a lymph node, the surgeons might be able to take that out, and then you treat the disease with medicines that we talked about, or radiation, etc. Metastatic can still be treated, but it may be more things that need to be done.
So when I have a lump that is cancerous, it,
Yes,
it, it is um removed surgically.
can be. Once the surgeons say that they can get it safely.
I'm
Yeah.
I'm I'm, make, I'm making a point here. So if it
Okay.
is removed surgically,
Uh-huh.
sometimes you hear people saying, okay, the cancer has returned. If a lady has a breast cancer, for example, and they take out the cancerous growth, is it that more of her cells turn into tumors and go over again, or is it that this person just has a predisposition towards developing that kind of growth?
Wow. So your questions are really, really, really good. I can see that you are just deeply thinking about that. So this goes back to our very first presentation. Remember, we talked about the fact that I'm looking at you and you are looking at me, but we're made up of tiny little cells.
Yes.
And these cells can sometimes behave badly, and they can grow and form a mass, which we might call the tumor. Now, you can remove what you see, but there may be the possibility that little tiny grains of sand are left behind.
Oh,
Yeah. So the little tiny, usually what happens is, if there's, so what you, the surgeons would, as long as the surgeons believe that they can remove something and do so safely without damaging the rest of the body, they will. And they will remove, now I don't mean to make you laugh or anybody laugh, but I don't know if you've ever eaten like a mango and it had like a bounce on it. You call it a bounce. You don't want to
mhm.
throw away the mango, but you want to cut out the part that you think has problems. But you
Yeah.
will go a little bit around it because you don't want to take anything that tastes nasty, and you will eat the
Mhm.
rest. So what they
Okay.
will do is that they will take out what they can see, but they will also take a margin to make sure that they clear it as much as they can. But they're only doing that but they can't take care of every little tiny grain of um, sand that might be left behind. So that's where the specialist, who's the oncologist, comes in and then adds on board medicines and other treatments to kind of go through the body and seek out these little cells that might remain and remove them. So that's why you might hear some persons, they're advised to have more than one kind of treatment, especially if, when you look at the cell under the microscope, the pathologist looks at the cell and they realize, no, this is a cell that looks like it's, if we leave any of this behind, it's going to want to come back. They're going to make those additional recommendations. Now, sometimes there are some persons who have cancers that can regrow in the similar location that are slightly different. So usually the doctor will still, unless they're absolutely sure by some other means, they might still want to check that it's the same kind of cancer that is recurring, because there are some people that might have a slightly different modification if it regrows, especially in the same place.
So after the if surgery is a treatment option, after the surgeon removes the tumor, that tumor is, I suppose, analyzed by the pathologist or
That's
whoever
right.
else, and it's going to help them to figure out, hey, this is not so dangerous. That is something that we need to follow up. Because sometimes I hear people saying, well, the doctor said they think they got everything, but they still want me to do chemotherapy. Why
That's
do I
right.
have to do it if I got everything? So now I'm getting a
That's
sense of,
exactly why. Because
yes.
they're little dust particles that are left behind, so to speak. So the doctors might say microscopic disease. that you cannot see, and you just want to make sure that you give the person the very best chance.
Wonderful, wonderful. I really do appreciate that.
I appreciate the question. I've never had that question before in that way, so I appreciate the
Oh,
opportunity to
okay.
try to explain it.
All right. On
Yeah.
Let's Talk, we do things differently.
Yeah, that's good. That's good. That's good.
Yeah. Now, you mentioned not very long ago that, sometimes you recommend a change of behavior depending on what the situation may be. Now that does sound as though some cancers can be lifestyle related.
Absolutely.
And so I want to ask you, because I think this is important. I know, I heard our health minister saying the other day that lifestyle diseases destroying us and they're doing all these things. So in this case now, given that diet can play a significant factor in the development of colorectal cancer, and you did go through last week some of the kinds of things that we need to avoid. Outside of diet, are there other behavioral things that can impact exercise, perhaps? I don't know. I'm just asking.
Yeah, yeah.
So can you
Yeah,
elaborate?
sure. So the good thing is, and I say the good thing, is that most of the diseases that seem to impact us now, separate from the infectious diseases, whether it's diabetes, hypertension, stroke, the heart attacks, the MI, so that cluster of cardiovascular disease, there's even increasing evidence related to Alzheimer's even. A lot of these things are connected to our lifestyle. So while I'm speaking about colorectal cancer, I'm going to also talk about some of the other common risk factors.
Mhm.
So one of the things that is important for colorectal cancer and all cancers, actually the most recent evidence would suggest that there's no safe limit, although you will still see some persons writing excessive consumption of alcohol. Okay, so I'm going to start there. And sometimes in the Caribbean, we respect person's choice, and alcohol is available quite freely, whether it's the beer or the rum, etc. And it's very much part of our culture to work hard during the week. I don't know what y'all call it, pass by the rum shop on Friday nights, kick back a couple with the people. Then on Saturday you might do the same thing. Then on Sunday, so we may even have a binge culture, a binge drinking culture as well. Not so much during the weekend, weekday, but then maybe on the weekend. So what I'm saying to persons listening is, as it relates to colorectal cancer and many other cancers, alcohol consumption increases your risk. Okay. Now, putting aside alcohol, another big one, and depending on things like lung cancer, we touched on this. Tobacco consumption is also going to impact your risk of colorectal cancer. And then one that I personally struggle with because of an injury I had. I used to like to exercise, not so much now, but I have to keep reminding myself that exercise reduces the risk. Okay, so if you are being physically active, walking for active transport, getting in 30 minutes of moderate exercise 5 times a week, you are going to be reducing your risk. So in other words, the flip side of that is being sedentary. So I know you guys can't tell, but I am at home and I'm actually standing. So I have a thing that I put together. It's like a shelving system, and then on top of it is a standing desk. And it is so easy for many of us to be sedentary, to just sit. And there's a separate evidence about the role of sitting, just sitting. So you want to break up your physical activity. You want to get up from your desk, get up from wherever, if you're watching TV or whatever. You want to move around as much as possible. So being physically active reduces the risk. Being sedentary increases the risk. And then in addition to that, we talked about the meats and so forth in terms of how the meats are prepared and stuff like that. But I just want to emphasize that a diet that is high in fruits and vegetables, things that are going to give you fiber, and then in water consumption as well, that's also going to be beneficial. So as you're thinking about how can I realistically over time work with my family, work with my friends to modify my colorectal risk, I'm going to be thinking about my alcohol. If I'm drinking it, I'm going to be putting it aside. I'm going to be reducing this tobacco consumption. I'm going to be trying to become more physically active. I'm going to try to increase my fruits and vegetables. I'm going to increase my water intake. I'm going to reduce my consumption of red meats, charcoal grilled red meats or processed red meats. And I'm going to try to adopt a healthier lifestyle where I'm sleeping and I'm resting. And I know sometimes it could become like a bit overwhelming. It might sound like people are preaching to you all about all this lifestyle modification and stuff. And some persons will say, well, I gotta die from something, just let me throw caution to the wind. I think you're doing this program because we don't want persons to throw caution to the wind. We want
Mm-hmm.
persons to make informed choices. Even small changes can go a very, very long way. So yeah.
So at work, for example,
Yeah.
rather than picking up the phone and calling my admin assistant, I
Yeah.
walk to the room because
Yes.
it gets me moving, you
Good
know?
job.
Yeah.
Yeah.
So these are little things we can do.
Yeah.
When you go to the supermarket, don't try to find the
Close.
nearest parking
Yes.
to the
Yeah.
door.
Yeah.
Deliberately park a little further so you can move.
Yeah.
And
And also just sorry to cut you off. No,
that's
finish.
okay. Go ahead. Go
That's
ahead.
no, I was saying like even changing your shoes. Changing your shoes can make walking easier or more comfortable. So for us ladies, we tend to wear, maybe a little heel or more firmer shoe. Maybe
Mhm.
convert that to something flat that's comfortable, that's flexible, and you'll be amazed how willing you might be to walk those few extra steps and keep moving. So yeah, yeah.
Now, on the alcoholic factor, some of us, I mean, as you were speaking there, I was saying to myself, thank God for the Seventh Adventist Church.
Mm.
We talk about New Start, we talk about celebrations, which of the acronyms you may wish to use, but if we really follow the lifestyle that we promote, it would do us so well. One of the struggles many of us have is food combination, sugar
Oh.
and milk. I understand. You help me out here that can be a combination that can be turned into alcohol. Am I correct? And what does that do for the individual? They may not drink alcohol, but they're eating a lot of ice cream and those kinds of things.
Why are you pulling out the stops? So So there are some things I know that are within our health message that current literature is now catching up on. Okay, to be fair. So since the intermittent fasting and stuff like that is something that for maybe the last 100 years or so we've had, and if we practiced it, we've been having the benefits of it. So one of the things that I know that I'm talking to a mixed audience across the Caribbean and otherwise. So one of the frameworks that we have within our health message is to avoid things that will naturally ferment. Now, technically, and also naturally ferment as a pathway for triggering digestive system changes and then probably leading to different growths. This is why it doesn't map it out completely. But as far as I'm aware, the pathway for the milk sugar combination is is still not a heavy science thing that I can't think right now of like how many of a systematic reviews heavy on this particular point. But what you will hear about is avoiding excess sugar, yeah, avoiding added sugar into your diet because we know that this is allowing me to talk about a risk factor that I forgot, which is a very important risk factor, has been like respected for at least the last 14, 15 years so that's obesity, right? So the pathway that I'm thinking about is obesity and colorectal cancer. It does increase the risk, and I should have mentioned that. So the added sugars then are the excess sugars. There are calories that you can't necessarily burn off, and then they're going to add to the likelihood of you having a larger, what we call a body mass index, higher weight compared to your height than you should, and especially weight that fat that comes on around the tummy area, so central obesity. So the mechanism in most regular science will be that combination of adding in sugar, excess sugar, but not necessarily the sugar milk combination. Now, granted that there's a lot of work now on something called the gut microbiome and how different kinds of foods can alter the gut microbiome and how the gut microbiome is then feeding into some of these diseases that we see, including and also affecting our mind. So I would say that it might be an interesting space to watch how the science develops. But we already know that there are some people who might have might not have enough enzymes, certain of some enzymes in their stomach, and the way how they digest milk might be a little different. The way how they might digest quickly digesting foods like fruits versus things like high fiber foods might be different. So those persons may already know that they need to work along with a nutritionist to work out their particular food combinations. But right now, I don't want to make a recommendation about that, but I do know that it's in our literature for more than 100 years.
Okay, wonderful. Maybe last question on colorectal cancer. Is it equally distributed among the sexes? Do we have
Okay.
a higher incidence in male as opposed to female, or vice versa?
Yeah. So in most countries, you will find a slightly higher proportion of men having colorectal cancer than women. But generally, colorectal cancer is one of those cancers where the likelihood of you getting it is going to increase with your age. Yeah. So what we want to say is definitely over 50 for sure, you're well into your screening. If you're Afro-Caribbean descent or African ancestry, that age group is coming down to around 45. If you've had persons in your family, regardless of your ethnicity, you want to start that screening around 45. And if you have any of the genetic syndromes, or if you have, ulcerative colitis or Crohn's disease or any of those inflammatory bowel conditions, along with a couple other things, you're going to be working along with your health practitioner, your health provider, to start your screening at a time that is best for you. Yeah.
Okay, great. Now, I think we have you can never fully exhaust a subject, but I do want to move on to some other things.
Sure.
So on Let's Talk, we have in the recent past addressed the issue of breast and prostate cancer. So I'm going to not spend too much time on those, although they may be pretty popular and people need to be reminded every now and then. I have, however, also been made to understand that stomach cancer is also relatively common, at least on the global level. So can you share a bit on this? What is the cause and how do we avoid it?
Okay. So just want to clarify, Dr. Greene, am I going to after stomach come back to a little bit of prostate and breast, or just you want me to just see
No,
how
you
the
can
time goes?
just go. With the I think we did touch prostate and breast sometime in the past
Okay,
recently.
you had other shows. Okay, no problem.
Yes.
Okay, all right. So stomach then. I think 2 shows ago I was demonstrating or last week, how the GI system is. So we chew our food technically in the normal system. It goes down the throat. It goes down into the esophagus, or what we would call in the Caribbean the swallow pipe, and then it goes into this sac, very muscular sac. And that muscular sac is attached right onto the bottom of the esophagus or the bottom of the swallow pipe. And that sac is what we would call the stomach in anatomy. So when we say stomach cancer, that is what we're talking about. We're talking about that small sac that is attached onto the bottom of the swallow pipe. That is a storage sac that helps with digestion, particularly of things that contain protein. And then food empties from that sac into the small intestines and then onto the rest of the digestive system. Because I say that because sometimes when we say stomach, we mean like the whole belly. But this is what we mean. We're talking about that small sac. Now, very interestingly enough, there are a couple of things in our region that could be contributed. We tend not to have, it's not one of our top 3 cancers, but we do know that it's a cancer that is important because it's one of those things that if picked up early, a huge difference can be made as well. So in terms of risk factors, the 3 that I would want to emphasize, so yes, alcohol and tobacco are going to be there as well, but there are, in particular, there is an infection, a bacteria. So this is one of those cancers that the trigger point is actually an infection. Yeah. So there's a particular bacteria called Helicobacter pylori, And it's the most common regions for stomach cancer tend to be like China, Mongolia, parts of Asia, etc. But throughout the world, it's becoming increasingly important. So Helicobacter pylori infection, and the bacteria can be passed on in saliva. It can be passed on what we call fecal oral route, so it can be passed on in stool, etc. And if you have this bacteria, it causes inflammation in the lining of the stomach that if it is not treated, it can cause the cells to change, to behave badly, and to become cancerous. So one of the things we want persons to know is that it is wise to get tested for H. pylori bacteria, because in some Caribbean countries, it's endemic, meaning that we do have that bacteria circulating in our populations. So usually, some of the signs and symptoms might be signs and symptoms of gastroesophageal reflux disease. Some people might call it very similar to like heartburn, persistent heartburn that's not going away. So usually if that is happening and your doctor is treating you with anti-acid medication to settle that heartburn, etc., and it's not going away, I'll give you some of the symptoms of the gastroesophageal reflux disease. We want you to remember to say to your doctor, can you test me for H. pylori? And it can be done in a blood test, and it can also be done in a stool test. And if you come back positive, there are antibiotics that can be used, and then there's anti-inflammatory medication, so to speak, medication that stops that inflammation, stops the stomach from producing so much acid and gives any inflammation or ulcer areas opportunity to heal. So let's talk about some of the signs of gastroesophageal reflux disease.
That's before you go to the signs there.
Sure.
Because I know a few persons
Yeah.
who did share with me that they had some serious stomach issues, serious enough stomach issues, and the doctor said that they had an H. pylori infection.
Same.
So now I just took that as, it's a bacterial infection. But are you suggesting that this could go on to lead to cancer?
Yes. I'm
Okay.
not suggesting, I'm definitely saying.
Okay.
Yes. So that's why, and the treatment for the H. pylori, that's why the doctor that your friend would have gone to would have most likely put them on something called triple therapy. And you have to use the triple therapy for at least 2 weeks until the infection is cleared. And that's why that doctor would have prescribed. That's one of the few instances where you would get prescribed antibiotics for a long period of time, because you don't want a chronic inflammation of the lining of the stomach from H. pylori bacteria. So I would say to anybody, I know for sure in Barbados, where I am based, the test is very freely available, very low cost. I would say to anybody who is having persistent reflux symptoms and don't panic now, don't panic, but just have a conversation and get checked. Is definitely going to be worth it. Yeah.
So now
So
we can go on to the symptoms. Yes.
okay, right. So how would you know? So the reflux tends to be fairly similar. Most people recognize when they're having a burning sensation, which tends to be in the middle of the chest, just underneath the middle of the breastbone. Sometimes it will feel like it is boring through to the back. You might notice that when you eat certain foods, you might feel a little bit bloated. You might have the sensation of a bitter tasting liquid coming back from coming back up the swallow pipe, and you're tasting this metallic, bitterish taste in your mouth. You might find that, well, in Beijing, people will say that they find that they repeat their food a lot. So you've eaten, but then you find that you're burping and you're belching, and you just have this, this nasty taste coming back up. And then also your mouth might be springing a lot of water, or you're salivating a lot. And then also some people, if it's really bad, they then get like a sore throat and that kind of a thing. So your doctor would usually ask you about these kinds of things, and then they will make lifestyle changes. So they might tell you to, come off of anything that is acidic, so that your ketchup or your mustard or whatever, not to mix your oil and your onions and various things, greasy foods. They might take you off of peppery foods or spicy foods and fizzy drinks and chocolate or caffeine and those kinds of things. And they will tell you not to lie down after you eat, and you have to, stay propped up. And it's supposed to technically settle with those kinds of treatments and those kinds of interventions, along with some very common medications that are used to stop the acid being produced in your stomach. But if for sure that is you're not getting better, you cannot stay on something for months. There's a reason why it's not settling. And I would want to encourage persons. It does not have to be stomach cancer or anything like that. It could be something else that's going on. Anything from really bad sinus drip to something else that's happening with the esophagus or the diaphragm. But you just need to get that checked. So H. pylori infection for sure for stomach cancer. So the other thing that I wanted to mention was that there is an association between stomach cancer and the consumption of salt preserved foods. Okay, so like in Japan and in China and stuff like that, there's a lots of consumption of salt preserved foods. But in the Caribbean as well, we are small in developing states. We have a culture also of not necessarily, in the last 60 years, we're moving out of relying on salt preserved foods into fully fresh meats and produce and stuff. But in many of our islands, we're still having persons use a lot of still like salted fish, salted pork, those kinds of things that have been preserved in salt. And consistent, steady consumption of salt preserved foods is also one of the things that has been linked to stomach cancer as well. And then separate and apart from that, there's another infection that's not really common in our region, something called Epstein-Barr virus, that can also lead on to stomach conditions. And then there's some people who have a condition called pernicious anemia. It's a kind of anemia where your body is not able to absorb vitamin B12 properly. And so if anybody has a vitamin B12 deficiency because of pernicious anemia, especially, we try to make sure that their B12 levels are sufficient so that they don't have that increased risk of stomach cancer. Those are the top ones that I want to mention right now, but with specific emphasis on H. pylori infection or Helicobacter pylori infection, which is the main thing. Getting Helicobacter pylori infection treated, thinking about how what you're cooking in terms of the salt preserved foods. And also, if you have pernicious anemia, your doctor has been treating it to be serious and compliant with your treatment, I would say. Yeah.
Just one question on the H. pylori.
Sure.
If an individual has an H. pylori infection and they receive the treatment, you're going to put them in the 2 weeks of bacterial treatment, of antibacterial treatment, and they recover. The changes, don't cook that, and so on.
Yeah.
Can they, after recovery, now go back to eating regular?
Yeah, they should. But remember that your doctor will usually do a test to make sure that the bacteria is clear. Your stomach should settle and you should feel better and you should go back eating in a healthy way. You shouldn't revert to the unhealthy practices that might have triggered it, but you should be able to. Now, I just want to say that because H. pylori can be spread by fecal-oral route, it means that you can, and you don't have necessarily control over everything that you eat and who prepares it and their habits. That is possible that you can get it, you can pick it up again, right? You can be reinfected. Yeah. So if it is that you're having signs and symptoms, persisting, it may be worth it to make sure that you haven't been reinfected. Yeah.
Okay. Now, moving on again,
Sure.
Wonderful bits of information there.
You're welcome.
I've also known a few persons who have been affected by cancer of the oral cavity, mouth, whether you want to say thoracic or lip or, what is responsible for the oral cavity becoming infected with cancer?
Yeah, so that is also very interesting. In our region, it's going to be, unfortunately, the alcohol, tobacco consumption usually. But it doesn't mean that people who don't also who might not have a change for whatever reason. In our setting, we tend not to chew betel nut. There is a fruit that some people chew, like a gummy fruit. If you chew tobacco as well, that can also cause changes in the mucosa of the mouth, the lip, the oropharynx, and that can also predispose. It's not something that we talk about a lot, but we do know that there is evidence to suggest that pharyngeal, back of the throat, pharynx area, way back, you can also have changes in that by virtue of human papillomavirus infection. So it's a group of viruses, about 70 plus viruses. Some of them are high risk. In terms of increasing the likelihood of a person getting cancer, some of them may just cause warts. But we do know that that it can be passed on from one individual to the next. And if you have HPV infection and you can have penetration into the mouth or into the back of the pharynx, that you can get HPV related or pharyngeal tumors. But for the most part, I would want to mention the use of alcohol, the use of tobacco. I would also want to mention, although it's not relevant to our region so much, for those who might still be chewing tobacco, separate apart from smoking, and then the chewing of the betel nut as well. That is those are some of the risk factors. And then we would say H. pylori, not H. pylori, human papillomavirus, high risk subtypes for persons who may be practicing sexual activities in particular that may predispose them to having that kind of exposure. Yeah.
Okay, wonderful.
Sure.
Let me, I really wanted to ask this one, and I think we have enough time to get it in.
Okay.
A cancer can metastasize from one organ to another. So that, for example, prostate cancer may spread to the liver, I think you mentioned. I'm going to put the two questions in one in the interest of time. So if prostate cancer spreads to the liver, when it gets, do we still call it prostate cancer, or do we call it liver cancer? And secondly, certain cancers known to spread to certain organs, or any cancer can spread to any organ?
Okay. All right. So good questions again. So if the cancer has spread to the liver from wherever it was originally, it's still whatever it was originally. So, but if you would say, so say for example, I think you are in St. Croix today, I think you said, but you are from another island. Because you are in St. Croix, you're not a Crucian, right? You're just there.
Yes.
So that is one of the beauties of sometimes we do not know where the primary was. We don't know where the original cell was, but it may spread to some place like the liver or the lungs. And you may be able to take a sample from the liver or the lung or wherever it is, and by looking at the cell, you'll say, oh, this is in the liver, but really and truly, this has come from the prostate, or this has come from the breast. Yeah, so because it still has some of those similar patterns. Sometimes
the pathologist can take the cell and say, hey, this is in the liver, but this is breast cancer.
Correct.
So you must
Absolutely.
have.
Yeah. And sometimes there are some rare cases where the cell doesn't look like anything that you can recognize. And you just have to say it could be, it could be, it could be, it could be, it could be. And then especially in our region, we might need to send it to like another country, like someplace in the US for certain other analyses to help us to figure out where exactly it's coming from. But yeah, so it maintains its original origin. It remains, so it will be a prostate cell that has metastasized to the liver. So your second question is if there are certain cells that will go to different places. Now I've gone back to my mashed up box. The way how we are, the channels that run next to a tumor, they can sometimes go other places in the body. And therefore, if a tumor is going to spread, it might spread through the lymph system, or it can spread through the blood system. And therefore, things that share your same root might be the organs that might be affected. So say, for example, in Barbados, you can get on a bus, pay $3, and you can pass several roads without getting off. So technically speaking, the roads that are close to the tumor and things that share that road may be affected most. So say, for example, breast cancer, the channels for breast go underneath the armpit. The channels for breast naturally go down the middle of the chest. They naturally go into the collarbone area, and they naturally go into the neck region, and some of the blood vessels go similar places. So we know, for example, that cancer of the breast, although it could spread anywhere technically, it tends to spread to the brain, but I'm not giving it a frequency. It tends to spread to the lungs. It tends to spread to the liver. It tends to spread to the bones. It tends to spread to the brain. So say, for example, the prostate, the things that are around the prostate that share the similar channels, those might be the places that might be affected. So you might have your bladder being affected. You might have your kidneys being affected. You may have bones in the lower back being affected, etc. Colon, you may have the lining of the intestines being affected. You may have the liver being affected because some of the circulation has to flow through parts of the liver. You may have your lungs being affected. So a lot of it has to do with where the channels, shared communication, shared location, shared channels for either blood or the other fluid that I had mentioned before called lymph. So sometimes if you're examining a patient as a doctor and you pick up that you're feeling a lump in a particular place, then in your mind, even if the patient has never said, something's happening with my breast, if I'm examining a patient and I feel a lump up here or up here, I might say, may I check your breast, please? So sometimes you might not know what's happening at the primary, which is the location of origin, but you might pick up something that is distant. Yeah.
Okay, so it's kind of like if you're traveling late, you're likely to stop at this place. That is normal for the time being. But
Exactly.
yeah, the route that they travel on, some cancers, based on where the organ, what organ it is, they're likely to spread to those other organs. Now
Correct.
that's pretty interesting.
I'm
Yeah.
going to use that example next time. Later.
Okay. Okay.
Or into
Well,
island travel.
yeah, we are just about done, eh?
Yeah.
But can I just squeeze one last question in?
Sure,
Because
sure, sure,
it
sure.
just came to my mind. I only know of one person who died from bone cancer in the Caribbean. Maybe there may be others, but I'm only aware of one. Is that a popular cancer around bone?
Yeah, so there are different kinds of bone cancers. Yeah. And unfortunately, there's a particular one so one, it's there. Yeah. So there may be cancers. Remember last week you asked me about carcinomas versus sarcomas,
Yes.
right? So a lot of the osteosarcomas still, yes, we will see them in our region. And osteosarcomas, particular types, especially unfortunately, you might see them in children and young and teenagers. Yeah, you might see the osteosarcs and various kind of sarcomas, bone sarcomas, um, um, in children. But you can also have, it's not so much a bone cancer per se, but there's a particular cancer called multiple myeloma. And although it's really about the blood and the blood system, it tends to involve the bones so much in terms of how it impacts the bones. I think a lot of people kind of get it mixed up, and that is fairly common in the Caribbean, and it's something that people should be aware of. Sometimes people pick it up when they're having bone pain, or they have a bone that just, it doesn't, the bone breaks without any serious trauma or force or anything like that. But the particularly I want to mention the osteosarcomas just because it can happen in children and teenagers, and the child is complaining for the bone hurting, etc., etc. And you're not really, you say it's growing pains. It could be growing pains, but any child that's persistently complaining about bony pain, especially long joint, long bone pain, so pain in their thigh, the knee area, the arms, etc., you want to make sure that that child is getting checked out. So for sure, yeah, yeah.
Well, our time has expired. Again, I want to thank you so much. We have been informed, really, really very informed. And I know that next week is a little iffy for you, but
Yes.
we'll try to see what we can work out. Because I do want to talk about treatment, but we shall see. We shall see.
And if I can say to everybody listening, go back and as you listen, don't be afraid. I think Dr. Greene has asked for these sessions so that people can be empowered. We do not want you to be afraid. There's so much that can be done to change and improve cancer awareness in the Caribbean. We started the day before World Cancer. We've gone on, World Cancer Day, we've gone on for 2 more sessions, and we'll try and see if we can work out a fourth, but don't be afraid. If any of this is resonating with you, talk to God, talk to a friend, take action. Yeah, don't be afraid.
That's a wonderful place to end today. Thank you so much. God bless you. Until next week when we have another edition of Let's Talk. God